Today, my task to talk about the new era of immunotherapy in the first-line metastatic non-small cell lung cancer. Well, this is my disclosures. And I remember when I started my residency program in oncology, when we used to treat lung cancer as a one disease, platinum-based chemotherapy. But nowadays, lung cancer is not a one disease. It's a group of diseases, and it's more complicated now, and we are choosing the treatment according to it's not only the histology, squamous or non-squamous, but also the molecular biology. And recently, with the evolving landscape of immunotherapy, we have the PD-L1 as a biomarker, adding to the other biomarkers for those patients with driver mutations. So it's an exemplar for the precision medicine in the non-small cell lung cancer. So you do agree with me that stage 4 non-small cell lung cancer, it has a very poor outcome, and it's #1 cancer-related death. Unfortunately, with the traditional chemotherapy, the outcome is very poor, with 1 year survival around 30 to 40%. And the 5-year survival at less than 5%. And whatever the histology, whatever the chemotherapy you are giving, the median survival between 10 to 11 months. This is what we know from the clinical trials. And since the evolution of the immunotherapy, which is now considered one of the main pillars of management of cancer in general, and specifically in non-small cell lung cancer, as immunotherapy, really it changed expectations of our patients as well as us as a physicians when it comes to the management and treatment of patients with advanced or metastatic non-small cell lung cancer. Recently, we have approval even in the earlier stages of non-small cell lung cancer. This is a very busy slide. As you see here, we have almost 5 immune checkpoint inhibitors has been approved in the first line from almost 10 phase 3 trials. And the questions, how do we choose the right treatment for the right patient in the first line, since we have all these trials and 5 checkpoint inhibitors approved in the first line? So let's talk about the immunotherapy as a monotherapy, and this is the phase 3 trials. Currently, we have 4 phase 3 trials addressing the efficacy as well as the safety of immunotherapy as a monotherapy in patients with high PD-L1 expressions. And probably the Keynote-024 is the first trial that's showing a significant improvement in overall survival. Currently, we have a 5-year follow-up of those patients, with almost 32% of the patients, they still survivors at 5 years of follow-up. And this has been confirmed in the Keynote-042, as well as in Empower Lung 1 for cemiplimab, as well as the Empower 110 for atezolizumab. If you're looking for the shape of the Kaplan-Meier curves, they are pretty similar. So this is a consistent evidence that immunotherapy as a monotherapy for high PD-L1 expression by itself, it's a standard of care, and it did improve overall survival for those patients. But did all the patients above 50%, they responded the same? This is on the left side of the slide. Real-world evidence data has been presented in the World Lung Cancer in 2019, showing that patients with high PD-L1 expression, 90% and above, they're doing much, much better than those having less than 90%. And the hazard ratio even very significant, 0.39. And this has been also proved in prospective trial, and this is for cemiplimab from Empower Lung 1, where the patients with the high PD-L1 expression more than 90%, probably they drive the main magnitude of benefit when compared to those patients with the 90 down to the 50%. This is another abstract was published in the Thoracic Oncology Journal and was presented in the World Lung Cancer in 2018, showing that the prevalence of PD-L1 expression and looking for high PD-L1 expression, and probably almost majority of patients, they have PD-L1 90% and above. And the question is, who drive the benefit from those high PD-L1 expression? So probably the highest expressors drive the greater benefit from the immunotherapy monotherapy. What about the low PD-L1 expression? Immunotherapy has been tested from 2 phase 3 trials, the KEYNOTE-042, as well as EMPOWER-110, and the two trials are identical, so they included patients with PD-L1 positive. And as you see here, there is no significant difference in the overall survival when using immunotherapy monotherapy versus chemotherapy in low PD-L1 expression, 50 or 49 down to 1, or in EMPOWER-110 for those intermediate PD-L1 expression or low PD-L1 expression. So probably only for those patients with high PD-L1 expression. What is attractive rather than the efficacy of the monotherapy is the safety profile. If you're looking for the grade 3 and above toxicity, it was very significantly lower in the immunotherapy when compared to the chemotherapy, which is ranging from 14% as in the EMPOWER-110 as well as EMPOWER-Lung1 for both atezolizumab and cemiplimab, up to 31% from the KEYNOTE-024. But in general, the safety profile of the immunotherapy as a monotherapy much more favorable when compared to the chemotherapy combination in those group of patients. That's why immunotherapy monotherapy now, it's a preferred and the standard of care in the first line high PD-L1 expression 50% and above. What about the immunotherapy chemotherapy combination? The landmark trial with the first trial has been showing an efficacy. It was the KEYNOTE-189 for pembrolizumab plus chemotherapy in non-squamous histology. And currently we have the 3 years follow-up, 4 years follow-up showing the 3 years efficacy from this trial. And in general, there is significant improvement in overall survival in favor of adding pembrolizumab to the chemotherapy, as you see with the hazard ratio of 0.6 and median survival approaching the 2 years. This has been also showing a consistent benefit across the subgroup of patients according to the PD-L1 expression, but probably the high PD-L1 expression patients, they drive more benefit when it comes to median overall survival, response rate, and even median duration of response. That has been also positive in low PD-L1 expression, as well as PD-L1 negative tumor. Probably PD-L1 negative tumor, they have very short median duration of response, lower response rate, and even median overall survival. But in general, adding pembrolizumab to the chemotherapy, it did improve the outcome in patients with PD-L1 negative tumors. This has been also showing benefit in progression-free survival. So we have significant improvement in PFS in favor of pembrolizumab chemotherapy when compared to the chemotherapy alone. This benefit has been across all the subgroup of patients. KEYNOTE-407 for squamous histology, and it was the first trial that's showing an efficacy in the squamous histology in the first line, combination of pembrolizumab plus carboplatin and taxanes versus the same chemotherapy. And this is the 3 years efficacy. It showed also significant improvement in overall survival. And at 3 years of follow-up, have almost 30% of the patients still survivors compared to 18% in the chemotherapy arm. Progression-free survival also has been improved, as well as response rate. But again, if you look for the patients with PD-L1 negative, you'll find that the median duration of response is almost less than 7 months. It's significant, but we're not expecting too much improvement in PD-L1 negative patients in this group of patients. EMPOWER-150, it was the third trial that's showing an efficacy in the first line. It's a unique trial. The design of the trial itself, the patient characteristic also different from the other clinical trials. So number one, they included patient with driver mutation, EGFR and ALK. So it's only for non-squamous histology. a 3-arm trial, 1:1:1 randomization, and they allowed bevacizumab in the standard of care. So they tried to compare the atezolizumab as a monotherapy plus the chemotherapy carboplatin paclitaxel plus bevacizumab. This is the arm B, versus arm C, which is carboplatin paclitaxel bevacizumab, or arm A, which is atezolizumab, carboplatin, and paclitaxel. But they're focusing on the arm B versus arm C, and they allowed a maintenance therapy, atezolizumab plus beva in the arm B, or a maintenance beva in arm C. So the rationale of combining atezolizumab and bevacizumab with the chemotherapy, that atezolizumab, which is checkpoint inhibitors, it has the capability to restore the anti-cancer immunity and preventing the T-cell deactivation, as well as the bevacizumab, which is established as anti-angiogenic effects. And we remember the data from the EP-05 trial that showing overall survival benefit by adding bevacizumab to carboplatin and paclitaxel versus carboplatin paclitaxel, and it has been a standard of care since that time. And also chemotherapy, it will induce cell death, which will release a lot of tumor antigens, and this will attract more dendritic cells or antigen-presenting cells. So by combining the 3 molecules, we are expecting to have a synergistic efficacy and improvement in the outcome. I think we all are familiar with the cancer immune cycle, and here where the destruction of the cancer cells will release the antigen. This will be picked up by dendritic cells or antigen-presenting cells, then will activate the T cells in the lymph node, then trafficking, followed by the tumor infiltration and tumor recognition of the cancer cells. So by adding bevacizumab, probably we may improve the priming phase by activating the T cells in the lymph node, as well as preventing the new vascularization and to prevent the escape mechanism of the cancer cells, and also to improve the infiltration of the immune cells to the tumor. Most important, it has a capability to restore the tumor microenvironment and to change the immunosuppressive microenvironment to immune impressive, or making the tumor microenvironment anti-inflammatory, which will attract more T cells. The second thing, that we don't have much data about the efficacy of immune therapy in patients with driver mutations. Most of the data comes from the second or third line, the OC trial, the Checkmate 507, and the Keynote 010. On most of this trial, they enrolled patients with driver mutation, but they excluded the outcome when it comes to the primary analysis for the intent to treat population. So how the outcome for those group of patients, and as you see here, for the arm B with the quadruple therapy, atezolizumab and chemotherapy, versus the arm C with the chemotherapy versus bevacizumab, it was well balanced between the 2 treatment arms. And just to highlight, the patient with EGFR mutation around 10 to 11% in this trial, and ALK positive around 3%. So they included patients with driver mutation, and the percentage is not that high, which is reflecting what we are seeing in our area, assuming that the incidence of EGFR and ALK mutation is higher in this part of the world when compared to the Western population. But when it comes to the Western population, it's reasonable percentage of ALK and EGFR mutation. Just to highlight that in this trial, we have a significant number of patients with PD-L1 negative tumors, around 50%. The trial was positive. It did really improve the progression-free survival, and at 1 year of follow-up, we have 37% of the patients are progression-free in favor of the quadruple therapy, versus only 18% of patients on the chemotherapy alone, with a median progression-free survival improved from 6.8 months in the chemotherapy arm to 8.3 months in the quadruple therapy, with a very significant hazard issue. This improvement in progression-free survival has been consistent across the subgroup of patients, regardless the type of mutation. Those having ALK or EGFR mutation, they have derived the same benefit of progression-free survival. according to the PD-L1 expression, is still positive. Probably those with high PD-L1 expression, they derive more benefit compared to the low PD-L1 expression. One of the stratification factors looking for the high gene signature expression, and regardless of the gene expression, the trial was also positive. It's showing improvement in progression-free survival. Overall survival also has been significantly improved. As you see, the median overall survival has been improved from almost 14.7 months for the chemotherapy arm to 19.2 months for the atezolizumab and chemotherapy. Probably the two curves start to separate after probably a 6 month of follow-up or after finishing the chemotherapy. And the hazard ratio here is 0.78. So I talk about the 22% risk reduction of death in favor of adding atezolizumab to the BEVA and chemotherapy. Overall survival also has been consistent across the all subgroup of patients. Interestingly, patients with liver metastasis, we know that those group of patients, they in general doing very poor. So we have significant improvement in overall survival, as well as patients with EGFR and ALK mutation. If you're looking for the PD-L1 expression, so probably those with high PD-L1 expression, they have more magnitude of benefit, with the median overall survival exceeding 2 years. So have 25 month median progression-free median overall survival versus only 15 months. The same for low PD-L1 expression and PD-L1 negative tumors. But what is interesting, if you're looking for the control arm, we have very high median overall survival reported in this trial. So 16 months or 15 months or 14 months according to the PD-L1 expression. This is really higher than what we reported from other clinical trials. They showing also patients with EGFR and ALK alterations, and as you see here, there is a very significant improvement in overall survival in favor of the quadruple therapy. Hazard ratio is very significant, 0.54, and even the median not reached at the time of analysis versus only 17.5 months in the chemotherapy arm. And here, that patients with liver metastasis also will have significant improvement in overall survival. Same hazard ratio like in EGFR and ALK, 0.54, and the median survival improved from 9 months to 15 months. If you're looking for the response rate, probably the Empower 150 is the trial that reporting the highest response rate from the phase 3 trial in this setting, and probably it would be the best choice for patients with bulky disease. So we have 56% response rate for the quadruple therapy. This is for overall population, but for high PD-L1 expression, we have almost 70% response rate, and low PD-L1 expression, as well as PD-L1 negative. So this is a very significant response rate reported from this trial. Adding atezolizumab to chemo-bevacizumab, it did not add really more toxicity when looking for the grade 3 and 4 toxicity. So almost 50% for the chemotherapy arm, 57% for the quadruple therapy. So a small number of patients, they having more grade 3 and 4 toxicity. Most of the toxicity was, or I mean, the immune-related toxicity, it was skin rash and endocrinopathies. And if you're looking for the grade 3 and 4 toxicity from this trial, it was only single digit, so less than 5% reported in this trial. If there is any contraindication to bevacizumab, we have the Empower 130 looking for the carboplatin, nab-paclitaxel, and atezolizumab versus the same chemotherapy. And this trial also, they allowed patients with EGFR and ALK. And we know that if you remove the bevacizumab, there was no benefit in those group of patients with ALK and EGFR. This information has been obtained from the Empower 150. So in this trial, they allowed also maintenance atezolizumab in the investigational arm, or pemetrexed in the control arm. And also they allowed crossover at type of progression in the control arm. This trial has been reported as positive trial. It did improve both progression-free survival as well as the overall survival in this group of patients. And since 2019, atezo, nab-paclitaxel, and carboplatin has been achieved if the approval in patients without EGFR or ALK mutation. So what about the safety profile from the main phase 3 trials in this setting? And this is the Empower-150, the Keynote-407, and the Keynote-189. So I will focus on the grade 3 and above toxicity, which is as low as in the Empower-150, 55% or 52% for the Keynote-189. For the Keynote-407, we have very high incidence of grade 3 and above toxicity, approaching 74%. Moving to the IO chemotherapy combination, and the first trial, which is the CheckMate 227, and probably this is the largest phase 3 trial in this setting. They recruited almost 1,800 patients with the stage 4 non-small cell lung cancer. They allowed both histologists, squamous and non-squamous. They excluded patients with the EGFR and ALK. So it's two parts, part with the PD-L1 expression and another part which is exploratory, the PD-L1 negative tumors. So let's focus on the part of the PD-L1 positive tumors. 3-arm trial, the control arm is the chemotherapy alone, or Nivo-EP, or nivolumab as a monotherapy. So in this trial, overall survival was the primary endpoint in patients with PD-L1 positive tumor. Trial was reported positive. We have now 4 years follow-up from the CheckMate 227, and as you see, for the overall population, have almost 30% of the patients still survivors at 4 years, which is very significant, and in favor of the Nivo-EP when compared to the chemotherapy arm. Probably the nivolumab arm is not significantly improve the overall survival, and this already well known from that CheckMate 026, which failed to show any significant improvement overall survival for nivolumab as a monotherapy. The only point that if you're looking for the first 6 months where the chemotherapy is doing much better than the immunotherapy, it's probably because of what we call the hyperprogression. So we don't know which patient those develop the hyperprogression, and after 6 months of the therapy, you will see that there is crossover of the curve where the immunotherapy arm, it did improve the overall survival. If you're looking for the histology, Nivo-EP, it did improve the overall survival regardless of the histology, and probably those with the non-squamous, they have more patients at 4 years of follow-up, 32% is still survivors, and we have only 20% in the squamous histology, but both are very significant. So to avoid this hyperprogression, they designed the second trial of the CheckMate 9LA. So why to combine Nivo-EP? Probably because of the median duration of response. So they reported the longest median duration of response in favor of Nivo-EP when compared to chemotherapy. So here, after 4 years of follow-up, we have still 34% of the patients, they maintained a response, which is, in my opinion, very significant. Coming to the CheckMate 9LA study, and it's a copy-paste from the CheckMate 227, but with only 2 cycles of chemotherapy in the investigational arm. So they allowed patients with stage 4 non-small cell lung cancer, both histologists, and they excluded EGFR or ALK or any patient with driver mutations. A patient received Nivo-EP, but the dose of nivolumab here, it's 3-weekly dose, 360 milligram, and the ipilimumab every 6 weeks. And the chemotherapy according to the type of histology, but only 2 cycles versus the chemotherapy for 4 cycles. Here, the primary endpoint of the trial, overall survival. And as you see here, the overall survival has been improved. We didn't see any crossover in the curve here. So the 2 curves are separated from the start, probably because of adding chemotherapy to the dual checkpoint inhibitor. So for intent to treat population, we have a median overall survival of 15.8 months versus 11 months. And the progression-free survival also has been improved with the 6.7 months versus 5.3 months. Significant hazard ratio. And as I said, we are interested in the median duration of response, which is almost 13 months for the dual checkpoint inhibitors chemotherapy, only 5.6 months for the chemotherapy alone. But what is disappointing here, the response rate. Even with adding 2 cycles of chemotherapy to 2 immune checkpoint inhibitors, we have a response rate with 38%. Yes, it's significant when compared to the chemotherapy, but we do have a higher response rate from other phase 3 trials. So probably if we have asymptomatic patients, probably will not be the best combination. What is interesting from the CheckMate 9LA, the patients with PD-L1 negative tumors. If you look for the PD-L1 negative tumors, the median survival 17.7 months, which is quite interesting. And if you look for the PD-L1 positive tumor, the median survival 15.8 months. And high PD-L1 expression, we have 18.9 months. It's not that impressive, but I was impressed with the median survival for patients with PD-L1 negative tumors, as well as the median duration of response. If you look for the PD-L1 negative tumors, the median duration of response 17.5 months, which is the highest median duration of response reported from any phase 3 trial. So probably if I'm going to use this combination, and if the cost is not an issue, probably patients with PD-L1 negative tumors are the best candidate for this combination. Last trial has been just presented in the World Lung Cancer Congress last year, the Poseidon trial. In the Poseidon trial, also they tried to explore the efficacy of the combining chemotherapy and immunotherapy. And here we're looking for the durvalumab and tremelimumab plus chemotherapy, or durvalumab chemotherapy versus the platinum-based chemotherapy. So they included both the histologists and no EGFR or ALK alteration, so it's 1:1 randomization. All patients received maintenance therapy, durvalumab plus pemetrexed in the first arm, durvalumab, tremelimumab, and pemetrexed, and pemetrexed in the control arm. What is make a difference in the Poseidon trial from the, for example, CheckMate 9LA, that they give only 4 cycles of tremelimumab as a priming. In 9LA, they giving continuous ipilimumab. So the primary endpoint is progression-free survival as well as overall survival for the patient with durva chemotherapy versus chemotherapy, and durva-tremi chemotherapy versus chemotherapy as a secondary endpoint. So durvalumab chemotherapy, unfortunately, it did not improve the outcome when compared to the chemotherapy arm. As you see here, there is no significant difference in overall survival. And when you're looking for the durvalumab, tremelimumab plus chemotherapy versus chemotherapy, we have significant improvement in both progression-free survival as well as the overall survival. So the overall survival here, 14 months versus 11.7 months. So how to choose between the Poseidon trial, if it's approved, or CheckMate 9LA? Probably we have a short course of anti-CTLA-4 tremelimumab, so it might decrease the cost. And still we need a longer follow-up from Poseidon trial to see if both immune checkpoint inhibitors really will improve the outcome on the long term. But if you're looking for that 2 years of follow-up, we have only 32% of the patients. So probably we need to longer follow-up from this trial. What about the histology? Because they included both histologists. So patients with non-squamous histology, they drive the main magnitude of benefit when it comes to the durvalumab, tremelimumab, and chemotherapy. And unfortunately, those patients with squamous histology did not drive any benefit. So the trial did not improve the overall survival in patients with squamous histology. And if you allow me to share with you some of my experience, some cases in my experience in the first line setting. And this is a 50-year-old lady. She has no comorbidities. She's never smoking. This patient started to have prolonged cough and low back pain. She has a CT chest that showed a large lower left lung lobe mass, and she underwent a biopsy from this lesion. It proved to be a lung adenocarcinoma. She has a PD-L1 positive of 40%. EGFR and ALK both are negative. The tissue was not enough to do further profile, and we did a bone scan that showed multiple bony lesions, and her brain scanning showed only solitary brain lesion. So I decided to give her atezolizumab, bevacizumab, and chemotherapy. The reason behind that, I believe that in the female never smoker, probably she has some sort of driver mutation that I might not know. So why not to give her the quadruple therapy, which is effective and working in patients with driver mutations such as EGFR and ALK. So this is just after 3 cycles of treatment, and you see nicely the lesion has been decreased in the primary tumor, and as well as the bone scan showing response for the bony lesions. And most interestingly, the patient with the solitary brain lesion, she refused to have any surgery or stereotactic radiotherapy. And when we did assessment, we found that she has almost complete response in this solitary brain lesion. This is another case of 58-year-old gentleman. He's having dyslipidemia and hypertension. He's a heavy smoker. His symptoms started since March 2020 with a cough and sputum, as well as shortness of breathing. And he delayed his investigations because of the lockdown and the COVID pandemic. Starting investigation by CT scan in May 2020 that showed multiple mediastinal lymphadenopathy and hilar mass, as you see here. This is a multiple mediastinal lymph nodes. And lung biopsy proved as adenocarcinoma with the high PD-L1 expression and 90%. ALK was negative, EGFR was wild type, ROS negative. But I don't have information about the other biomarkers because the tissue was not enough. And this patient, when we did a staging a CT scan for the abdomen, we found that has large adrenal metastasis. Bone scan also shows bone metastasis, as you see here. So I chose atezolizumab for this patient. The only reason that atezolizumab is the cheapest immunotherapy in my country, so I prefer to use it when it comes to the cost. But the data, it was consistent, as I show you in the initial presentation, among the 3 checkpoint inhibitors in high PD-L1 expression. So as expected, those patients usually responding very well. And this is the first assessment CT scan showing a good partial response when it comes to the primary tumor as well as the mediastinal lymph node. The same reduction in the adrenal metastasis. And this is another scan almost after 1 year of the therapy, patients almost have a complete response in this setting. And as you see here, there is a further response. This is in November 2020. One scan also showed a good response for the treatment. And this is a further reduction in the tumor. And again, it's hardly to see the previous lymph nodes. This is just his last CT scan in February 2020 after 2 years of a checkpoint inhibitor, atezolizumab, that showed the patient has a complete response. So this is just 2 patients as an example how the immune checkpoint inhibitors are changing the outcome for our patient when it comes to the first line. So I would like to thank you for your attention, and I'll be happy to take any questions.
Sir, thank you for your nice presentation and enlightening us with your experiences. Now, the floor is open for question and answer session. So anyone, if you want to ask question, please, you can ask our speaker.
Hello.
Yeah, hello.
I am Dr. Shivashish Bhattacharya. Can you hear me?
Yes, sir.
Yes.
Yes, sir. Yes, sir.
So my question is, in these latest trials,
Yes.
the EGFR mutated people, EGFR mutated tumors are also included for immunotherapy. That makes the situation quite complicated. How do you go ahead with the test of the lung cancer block? First, we test the IHC that it is from lung origin, that is TTF1, as a primary lung cancer. Then should we go ahead with squamous adeno differentiation and go for PDL1? And if positive, don't go ahead with the EGFR testing. If it is PDL1, should we go ahead with the treatment of PDL1 base as a driving pathway, or should we wait for the EGFR and keep the PDL1 pathway away? If it is a driver mutation of EGFR, ALK or ROS, we start targeted therapy. That is the very important issue now.
Thank you for your question. If I understand the question properly, first, the last trial, which is a Poseidon trial, did not include patients with any driver mutation. Only Empower 150 included patients with GFR and ALK. For your question regarding the biomarker and how we, at least in my center, how we proceed. So first, BDL1 results, it comes just next day. It's by immunohistochemistry. So it's a simple test. And according to the platform that we have, you may have DACO-223 or the Ventana or whatever immunotherapy you have. So it's simple by immunohistochemistry. ALK also can done by immunohistochemistry. So this is two biomarkers that it's easy to be reported from the pathologist. And both are reflex tests. We don't need to request. Coming to the EGFR, the ROS one, the other biomarker, the MET amplification, even the KRAS mutation now. If you are deciding to give immunotherapy, so it's better to do all the panel of driver mutations. So currently we have 8 drugs or 8 targetable mutations has been approved and registered. So I will not feel comfortable to give immunotherapy, at least monotherapy, even patient with HBV expression without knowing that if they have driver mutation or not. This is for adenocarcinoma. For squamous cell carcinoma, we do only PD-L1, unless the patient never a smoker. So never a smoker, we may have some patients with driver mutation, but I will not. It's very rare to find the squamous cell carcinoma in patients. Those never smokers, usually they are smokers. But if I have a female patient, never a smoker, she's Asian, probably I have to wait and have to do the all driver mutation before decided to go for immunotherapy, monotherapy, or even in combination. Even in Empower 150, they include patients with driver mutation, but they receive TKI before enrollment in the trial. I hope this is clear.
Can I ask?
Yes, sure.
Okay. I'm Professor Emad Dawoud, a female patient of adenocarcinoma, the metastatic disease. So we planned for actually PD-L1 is 20%, more or less. In that case, we want to give her chemotherapy with pemetrexed plus carvadine plus pembrolizumab. In that case, but patient refused to get the chemotherapy. So is there only option for immunotherapy in that cases?
Thank you for your question. Well, if patient refuses chemotherapy and she has a PD-L1 positive tumors, we have 3 clinical trials address this point. we have the Keynote 042 for pembro monotherapy, and we have the Empower 110 for atezolizumab, and we have the Checkmate 227 for the Nivo EP in those group of patients. If I'm going to go for monotherapy alone, and if the cost is not an issue, I would prefer to go for Nivo EP for those patients. Pembrolizumab, as I showed, for low PD-L1 expression, as well as for atezolizumab for intermediate or low PD-L1 expression, did not improve the outcome. However, the Nivo EP, it did improve overall survival. We have a very long follow-up for this patient, 4 years of follow-up, showing that we have almost 32% of the patient is still survivors in adenocarcinoma, low PD-L1 in general. If she refused, whatever you have an access, if you have an access to Pembro, I know that Pembro achieved FDA approval in PD-L1 positive 1% and above, but the exploratory analysis from the Keynote 042 showing that those group of patients did not have any overall survival when compared to chemotherapy.
Can I ask?
But if you use and you have only pembrolizumab, you can go for pembrolizumab. But Nivo EP has a better data for those group of patients.
Thank you. But if I suggest her atezolizumab plus bevacizumab as is the adenocarcinoma, and is it possible to get some benefit from that?
You mean as a mono alone without chemotherapy?
Atezolizumab plus
without chemotherapy?
Plus bevacizumab.
I cannot answer this because there is no any trial addressing the PIVA and immunotherapy as alone without chemotherapy. So there is no approval for that, and I don't know the outcome. I will not use it.
Okay.
If I'm going to use it, I will use it in the combination with chemotherapy. If you have any concern about the toxicity, I have a long experience with using the quadruple therapy. It's very well-tolerated combination. Bevacizumab itself, it's well-tolerated drug. Immunotherapy, atezolizumab by itself, it's well-tolerated immunotherapy. So carboplatin and Taxol, the only issue with the chemotherapy, and it's a very common protocol, and we know that as oncologists how to manage the side effects of carboplatin and Taxol. Giving 4 cycles will be enough, and to maintain the patient on Beva and Atezo, it will be reasonable. If you don't want to give bevacizumab or you have a concern about the cost, we have the Empower 130 where the atezolizumab, carboplatin, and nab-paclitaxel only 4 cycles, and also it did improve overall survival. So this is an alternative option. But Atezo and Beva alone, we don't have any data to answer this question, unfortunately.
Okay, we have another question to Dr. Emad Anwar, please. The question is, would you please, a question from Chakraborty Bhaskar, that would you please share your experience regarding progressive neurocognitive impairment after immunotherapy in patients with carcinoma lung, adenocarcinoma of the lung with brain metastasis expressing high PD-L1? Thank you.
Well, in my center, we have been using immunotherapy since almost 2014, and I have been involved in different clinical trials, in the phase 3 trials, and we have a huge experience with immunotherapy and management of immunotherapy side effects in different disease areas. I never see patients with impairment of cognitive function because of the immunotherapy, so it's quite rare, and if it's reported, it's quite rare. Probably it's because of radiation if patient having brain metastasis and irradiated. So that's why I'll be reluctant to give the patient radiotherapy unless they are really, really symptomatic from the brain irradiation. As you see in my first case, patient with a solitary brain lesion, she was not symptomatic, and when I gave her the chemotherapy, she achieved complete response. So probably this patient will be on long-term follow-up. If she has radiation, she might suffering from cognitive function affection. So now the role of radiotherapy to the brain comes in less and less. I mean, metastasis in lung cancer, especially those with driver mutations, when these patients are having drugs that crossing blood-brain barrier and giving very high response rate and patient having long-term survival. But I never see patients with cognitive function affection because of immunotherapy.